Afternoon, everybody, and thanks very much for joining the webinar this afternoon. My hope at the end of this session, which we're hoping to wrap up at about 2 o'clock, is that you'll be better informed on where we're at in terms of the rollout of the new structures across the West and the Northwest. I'm saying better informed because I do think that we're making significant progress, and we've been working at this now for some time. And this is the most recent in a series of webinars that we've held to try and keep people up to date on the changes that we're implementing. But it's going to take us a bit of time yet, and so the purpose here is to make sure that you're as up to date as you can be on what's happening. Two of us speaking this afternoon, myself, first of all, with an introduction and welcome, an outline of the progress that we're making, and then a discussion around the sample IHA structures. And then I'm going to hand over to Pat, our Regional Clinical Director, Pat Nash, who will take us through the networks of care. And then, similar to what we've done in previous webinars, we've plenty of time for questions and answers. And there's well over 270 people so far on the webinar, and there'll possibly be more. So I'm expecting that there'll be lots of questions and answers. And we'll do our best to leave as much time as we possibly can for that. We might move on to the next slide, so if that's okay. I think it's really important that when we talk about the progress that we're making, that we acknowledge the context in which that progress is happening. And for me, there are lots of different angles on that, but I think one of the most important contextual pieces is that we're changing the way that we manage our health services right across the country and within this region as well, at a time that we're also continuing to deliver care. And not are we just continuing to deliver care, but we're continuing to deliver care at a time when there are increased demands on most of our health services, whether it's in the hospitals, through the emergency departments, or inpatient services or outpatient services, whether it's in community in terms of our mental health services, or whether it's in community in terms of primary care services, disability services, and the whole range of other services that are offered in the community. What we have seen this year is that there has been a growth in the demand on all fronts across our services. So implementing significant structural change in that context is not, it's not an easy task. It takes a lot of focus and it takes a lot of effort, and it's important that we continue to deliver good care as best we can while that's happening. So that's the first thing I really did want to acknowledge up front. The other thing that I wanted to acknowledge up front, of course, is that we can't do that without the input of a whole lot of people across our system. And I do want to thank people for that and the time that they've given to this. I think the time and commitment and energy that people have given to it reflects the fact that they want to be working in the best possible health services that they can be. They want to deliver good care to the communities within which we all live, the communities that we serve, and I think that's reflected in the time and energy that people have given to this process. But I do want to say as well that I appreciate that time and acknowledge the effort that people have put in. If you don't mind, Bella, we might just go back to the previous slide. It gives a little bit, it helps sometimes to look back a little bit just to understand where we're moving forward. So just a quick reminder for people, in our region, we've divided our region geographically into 4 integrated health areas, and you can see them there. We've got Donegal, we've got South Leitrim, or Sligo's Leitrim, South Donegal, and West Cavan, Mayo standing on its own, and Galway and Roscommon combined. So there are 4 IHAs, and just the map is there as a reminder to people, if you need it, of those 4 IHAs, a geographical division of our region. And to put that in context, you can see that the exact same has happened across the country. Across the other 5 regions, they have also been divided into IHAs, totaling 20 around the country in total. So we'll move on, if that's okay. So the first update that I wanted to give you is that we have made some changes at the regional executive level. So we have a regional health area management team. In fact, we had a regional health area management team meeting this morning. We were continuing to meet on about a monthly basis to deal with the issues, I suppose, that are relevant to the management of our services across our region. And I think it's fair to say that that management team structure is starting to bed in quite well and functioning quite well in terms of the various members of the management team working with each other to ensure that we keep oversight and strive behind the services that we're providing. A number of the names that are on the slides there will be familiar to you because they've been in post now for some time. So if we take the 4 IHA managers, they commenced in their roles at the beginning of October 2024. So they should be names that are familiar to most people: John Fitzmaurice, Mary Ward, and Cosgrove looking after Galway and Roscommon, and Dermot Monaghan. We also, as I say, we've appointed our Regional Clinical Director, Pat, who's joining us on the webinar today. Dr. Anya McNamara is the Regional Director of Population and Public Health. Liam Fogarty is our head of finance. Maria Ferguson looks after HR. Vincent Jordan has been appointed as regional director of technology and transformation, and Caroline Crawford, our regional director of communications and public affairs, is also with us on the call. There is a slight change at Estates. I think the last time we had a webinar, Micheál Keneally was our regional estates lead, and Micheál has moved on to a different role within the HSE, and this position is now filled by Niall Cleary. And our regional ambulance lead is JJ McGowan, and both Niall and JJ are members of our regional management team. The reason it's reflected in a dotted line there is that they report externally, they report nationally, but they're very much part of our regional team and contributing to the delivery of services in this region. There's one addition to our regional management team. You'll see that Mary Garvey's name is listed there under the Regional Director of Planning and Performance. Mary hasn't commenced in that role yet, but she has been successful at interview and is being processed for appointment, and hopefully will be joining us on the management team in the very, very near future. And we certainly wish Mary all the very best in that role. And again, Mary's name may be familiar to many of you across the region. She was previously the General Manager of Roscommon University Hospital and is currently working in the Business Intelligence Unit within what was the sales group and within the region now. We have also gone out on a couple of occasions to recruit the Regional Director of Nursing and Midwifery post, but unfortunately we haven't been successful in that. So we need to regroup and figure out what we're going to do with regard to the Regional Director of Nursing and Midwifery post. It's a really critical post for our management team, identified at a very early stage as being a really important part of that focus. So we do have to come up with a solution around that as well. I think the current slide is just outlining the progress and the work that has been done since the start of this year, and it goes back a little bit to what I was saying earlier on, acknowledging the work and the time that and effort that people have put in. You can see that there have been a number of workshops, and out of those workshops we've answered some of the questions that we needed to for ourselves as to how we're going to implement networks of care, for example, and Pat will pick up on that shortly, but also how we're going to manage the change process over the summer period. And particularly, I think we've been focused over the last while on the structures underneath the IHA managers and how they will work and how they will function. So I'll pick up on that in a later slide. But I do think that this slide reflects an intensive period of work since February. We're currently in what we're calling the interim phase, so that covers the period from October 2024 to March, and now we're in the implementation phase. So just to be clear on that, sorry, the interim phase from October to March, but now implementation from March to September. We move on again, so please, if you don't mind, Ella, thanks. So one of the key areas that has absorbed a lot of our time, and I would say appropriately absorbed a lot of our time, has been the structure under the IHA manager. The reason I say it's appropriate is because this is where services are delivered. While the regional management team is important from an oversight perspective, this is really where services are delivered. And so getting this right is absolutely critical to the delivery of good healthcare across the country and indeed across our region. This slide, even though it's busy, it's one that you'll have seen before, and I think one that people will have had a good few opportunities maybe to review and to try and get their heads around and to understand what it actually means. But if we start at the top with myself as REO, you can see that the reporting relationship then is directly between the IHA manager and myself. The example that we've used in this slide is around Mayo. So let's put a name on it. Let's say, so if the IHA manager for Mayo is Mary Ward, and Mayo itself is divided into three CHAs, community healthcare areas. So that's the first point that I'd make, and one that I'd like maybe people to take home with them. So the region itself is a geographical alignment along county boundaries. We've subdivided that into 4 IHAs, broadly speaking, not entirely, but broadly speaking, along county boundaries as well. And then within IHAs, we've divided them again geographically, and these are the CHAs. So that's a very important term for people to pick up on, but more importantly, that approach to geographical division of the region down to the CHA level. And the details around that are provided within that. One of the other key things that I think is important to note that we've arrived at in terms of our decision making is that each CHA will be managed by a general manager, and the services contained within it will be managed by a general manager. So again, we're looking at that middle box, and you can see GM CHA that reflects that. Of course, not all of our services fit neatly into that geographical alignment, and so it is necessary for us to have a head of service as well that oversees a number of services, including regulated services. And again, that's described within the box, the two boxes on the right hand side of that. It reflects, I suppose, a higher level of leadership and management that's required from the heads of service. It also reflects services that cross over some of the CHA boundaries, and it reflects the importance of being able to provide robust management structures for our regulated services, including our older people services, disability services, and our mental health services. I don't want us to forget about the hospital, because if we again go back to our example of Mayo University Hospital is a really, really important part of the delivery of healthcare across that county. We have an existing hospital manager in post, and all of the staff that are working within the hospital report up to Catherine, who's the manager in the hospital, and that will continue to be the case. So in many respects, there's very little change within the hospital, albeit that there are changes for people working within the hospital outside of that. Separate to this, integrated with this management arrangement, we also have the networks of care, and Pat's going to touch on that in a significant detail as he goes through it. So I'm not going to go over it too much now, except to say that it's really important that we look at this in its entirety. That we have that our intention is that we will manage our services through the general managers, through the heads of services, through the IHAs, and indeed through myself as well. But also through the networks of care that would be supporting the delivery of services across a number of networks across the region, with a particular focus on quality and patient safety. So there's a lot in that slide. I'm hoping that the information that we're providing to you today is building on information that you've already picked up along the way in previous webinars as well. And I think maybe now is an appropriate time maybe for me to hand over to yourself, Pat, to pick up on the network of care.
Yeah, can you all hear me?
Yep.
Great. I suppose one of the key tenets is that is looking at the networks of care, which are, I suppose, an evolution of what we've had in the hospital group, which was MCANs, or regional clinical directorates, and I suppose their focus as a multidisciplinary team, looking at driving the quality and the standards of care that we deliver across the region. I suppose one of my main objectives as the regional clinical director has been assured of that we can deliver the same standard of care, whether you're in Inishowen or in Connemara, and that we're following a consistent model of care, and I suppose what processes we can be put in place to be assured about the care. And I think the key enabler of this will be the networks of care, which are clinical or care group based multidisciplinary teams, which will be setting the strategy, helping us in the regional management team and how we get assurance at what metrics we should be looking for about assurance, how we're assured about the quality and safety, and providing the leadership. You might go on to the next slide. So I suppose just the 5 core functions, just to talk in more detail, and I suppose the networks of care are regional structures. They're not operational, as in the line management for the line management, the operational management sits within the CHA, which sits within the hospital, also within the integrated health area, the management structure. But they are looking at setting what's the strategy, how are we going to deliver neurology services, dermatology services, our disability services, what's the strategy for them to ensure the consistency of the care, and I suppose in what the mechanisms that to support the quality, risk and safety management, and to bring that subject matter, clinical and care group expertise to helping set the strategy and to provide the assurance around the quality and safety. And I suppose ensuring what metrics we're looking at. I mean, it is really important that we have mechanisms in place to be assured about the safety of the services and what metrics, what we're looking at, and then where there is any issues or anything of concern, what processes we put in place to address them, and bringing that clinical care group lens and focus to it. It also gives us the opportunity to have leadership, and I think we've really seen the importance of that leadership in the hospital groups. And I'm not saying, I know I'm coming from the hospital group background, but looking in the wider lens where you've got a regional leadership in a clinical area, a care group area, their role that they're going to have in helping us as the regional leadership team, but also being a key member of national leadership to set the direction of services going forward. And I suppose a key component of providing high quality, safe care is ensuring that we link with our academic partners, both the University of Galway and the ATU, and that we're focused on the strong role of teaching, training, and research, and high quality care settings, or those that have strong focus on academic and research functions. You'll be glad, and I'm not good at reading slides, so I'm not going to go through each of these individually, but it's just to say, when we look at the broad areas, the functions that we're looking at for the role of the networks of care. And I suppose the networks of care are there to provide relevant clinical or care group focus to support the implementation of the services at an IHA, within the CHA and the hospital level. And also to help the regional management team in the assurance they are not operational, they're not the key line management operational structure. And I suppose this is, from those of us who's worked in the hospital, it's a structure that we've had in place, and that people that initially there was concern about that would there be confusion about roles, responsibility, authority, but it has worked. It has worked very well in a collaborative approach. And I suppose from the community, as we extend out into the community, now there's an integrated entity in the regional health area that we want to kind of, it's a new concept, and I suppose it will take a lot of engagement, communication, and working through to make sure that that everybody understands, and that how it interfaces with the operational management structure. You can move on to the next. So if you look at the slide, if you look at the bottom, and I suppose the reason that we put the 4 IHA structures in the vertical but across the horizontal, that these are, it's an integrated matrix and a governance matrix. We currently have 6 networks of care, MCANs, that were hospital-based women's and children's, but we are going to look to develop a children's network of care. It's probably one of the key areas that has been highlighted, is how we look at an integrated care for children, rather than the, I suppose, more pillared care that currently exists, and that how we integrated within the community, but also integrated across the hospital. So, Hilary Stokes and Dermot Monaghan have a working group. They're setting up the first meetings coming up about how we develop a children's network of care. So previously we had women's and children's. I think it'll evolve to the women's and infants cancer we've had in existence, and all of these current hospital-based ones, we want to see how they extend, but that they will be hospital and community, not just completely hospital focused. Some of them may be more predominantly hospital. Perioperative surgery obviously is, but there is aspects of surgery, ophthalmology, etc., where we want to ensure integrated care. And particularly in medicine, there's significant now with the enhanced community care programs for chronic diseases and the integrated care program for older people, of ensuring the integration of the integrated care across the continuum for the patient. So when you look at the newer ones that we're looking at, we have the disability, mental health, older people, and children are the four newer ones that we're looking at. Key, I suppose, why these? Some of these are more entirely community based, or while the mental health was based entirely in the community, it does of course have a hospital and community focus. Older people, I see this, if we can get clearly integrated pathways, setting a clear strategy for older people, it will help enhance their care, but also we're helping the transition between home, hospital, and either home or continuing care, where often there's significant barriers or delays in the care of this vulnerable group of people. You can go on to the next one. So the structures, there's a work stream being set up to look in detail at the structures, but it will be a multidisciplinary team with clinical leadership or care group leadership. Not all of it is clinical disability, obviously, it would be a care group focus. We will be lending on the strength and the experience of the head of services that they would take a lead role in helping whilst being embedded in their own IHA, to take a lead role for the network of care, and particularly for those established ones and how we integrate them in the community, considering the heads of services are all coming from a community background. And then in particular in those networks of care that would have a more traditional community focus, to bring their expertise and leadership to that, to ensure how we develop the services and help having an integrated multidisciplinary team around it. You go on to the next slide. So that's just again some of the roles of the head of service, that we see them as key roles in helping us with the networks of care and bringing the care group focus to it. You can go on to the next slide. So I suppose where we're at with it, we are reconfiguring the current hospital networks of care, that they will, with our MCANs, into regional networks of care, and that we've set up a working group to progress the mental health network of care, and a separate one to progress children's network of care. We will, as Tony showed in the slide there is a regional disability lead to be appointed, and he or she obviously will have a strategic leadership role rather than an operational leadership role, and that role obviously would sit with the model of the network of care, again based on the principles of ensuring the strategy, ensuring the quality and safety oversight, ensuring the assurance processes that we put in place, and providing the leadership both within and without, and interfacing with the national structures. We will be progressing with an older people's network of care. And I suppose the final thing that we really want to, one of the key groups that have kind of sat to one side of structures in the community is general practice. We want to see how we bring general practice, the GPs, much more into our structures. They're independent operators, but they're key components of the delivery of our healthcare and community care services, and how we bring them in. And I suppose there is elements of the community services that don't fall within the above groups, and whether we should have a primary care general practice network of care is something that we'll need to explore and as we go forward. And that's only something that has kind of come up in recent times, but it is something that we will be exploring and in more detail going forward. So I suppose we're also one of the key roles for the networks of care, and in the previous language, the MEMCANs in the hospital was having a strong role in the quality and safety and assurance around services. And currently, I suppose one of the key things is the incident management and the structured approach. There's a national incident management framework has been revised at the moment, but what's called the IMF is the current thing that we work along. And there you can see the various functions about at the level, and this is just to give an example where an incident, obviously, if it occurs at a hospital or in the community centre, the CHA, IHA level has the operational oversight about it. The network is there to provide that assurance and to provide the support to that, bringing bringing that care group and that clinical lens to it. And I suppose they will help enable the regional structures and being assured about the standards of the incident management and the implementation of recommendations and supporting the hospitals. So the networks of care, the enabler of supporting and helping the oversight down to the community health areas, the hospitals, the integrated, the IHAs, but also helping to provide the assurance up to the regional management team. So I think that's all I was going to say, Tony.
So thanks, Matt. And I know there's a good bit in that for everybody. So I'm hoping that there'll be a few questions coming in our direction that that'll help to make things clearer as well. Caroline, are you feeling the questions first?
So we'll read out any questions. Anybody that has any questions, if you just want to type them into chat, and we'll go through each question. If we get cut off for time, we'll come back to you with a response. But we get through these pretty promptly, so you can just keep putting them into the chat function, and we'll go through them. And I see that there was Q&A.
Okay, so just while people are gathering their thoughts there on that one, there's just a couple of points of emphasis again. All of this is contained within the slides, but I think thinking about the management structure in an integrated way is really important. And that's why the slides present not just the IHA management level and the CHA management level, but the networks of care as well, extending across that in order to be able to describe how things will be run on a day-by-day basis across the region.
So, Tony, we have a question here about the children's network of care. Is that going to be separate from the women's and infants? And also, will the networks of care have any dedicated staffing?
You want me to take that, Tony?
Yeah, if you want that, go.
Yes, I suppose infants, neonates are always part of women's services, and I think we're setting up a work stream to look at the separation of the children's from the women's and infants, and that I suppose it's one of the key things I've heard repeatedly since I've started in this role is the need to have a child focused integrated approach in the community, but also in the interface between the hospital and the community. There is resources in place already, and that we'll need to look to see how we ensure that the networks of care are resourced with the necessary quality and safety business function supports to enable them to function.
And just following on from that, there was a question as to whether CAMS will fit into the children's network of care.
Well, I suppose this is where, and it has been an issue before, do things fit rigidly into one area? They don't necessarily need to. I mean, in the hospital, the example in the hospital is where our surgeons do cancer surgery and they do non-cancer surgery, and where they sit maybe predominantly within the perioperative, they have the interface with the cancer network of care for the cancer care. So I would see CAMS being absolutely key to being involved in the children's network of care, but they also sit within the mental health, and that's quite feasible to be in both. It isn't a line management, it's about setting the focus around the integrated delivery of services for children.
Okay. We have a question here on Joe Ryan's brief as the National Director of Public Involvement, Culture and Risk Management. Is there a similar in the RIO structures, or are these functions spread across the RIO RMT members?
Do you mind just checking that one with me again, Caroline? I didn't quite pick up on that question.
So Joe Ryan's brief as the National Director covering public involvement, culture and risk management. The question is whether there will be a similar role within the RIO structures, or are these functions going to be spread across a number of regional management team members that currently exist?
Yeah, so apologies now to the questioner if I get the answer slightly wrong on this, but I think the correct answer is say that they will be spread across a number of roles. So if we take culture, I would expect that to be led on by Maria Ferguson, who's our head of HR, so she will take the lead in respect of culture. With regard to public service user involvement, we're appointing a person to that role specifically within the region, and we would expect that appointment to be complete by the end of this summer, and the person taking up role probably reporting directly into our regional director of nursing and midwifery, who's the regional management team person that will take the lead in regard to that. And then in terms of risk comes under quality and patient safety for us.
Will there be a regional director for health and social care professionals?
So yeah, and again, if we go back to the organogram that we had on the regional management team, that position wasn't in the slide that we showed. I think the reason is because it hasn't been finally decided that there will be a health and social care professional representative on the regional management team. We are definitely taking steps towards that. I have to say, we've agreed a draft job description and what that role might look like and where that person would fit in within the work of the regional management team more generally, and how that might work within the context of the region. However, we are still at a point where we're agreeing these positions, some of these positions, with the relevant unions, and we haven't that one finalised just yet. I'd hope we'll have it finalised by early September, and I'll come back to that date again before we finish, but I would hope we'll have it finalised by then.
Only one here for staff health and well-being. Where will that sit in the new structures? Will some elements sit in HR and the health promotion elements remain in health promotion?
So that's the question is probably also already answered in the question, if you know what I mean. So yes, I would say that significant elements of staff health and well-being will be within HR, and there's no doubt about that. That said, we employ 23,500 people across this region, and of course all of those 23,500 people are living in homes and communities and so on, so they're very significant reach in terms of the health and well-being of the general population as well. So having that connection between our staff health and well-being and general health and well-being is really important. What we're progressing towards on health and well-being is that health and well-being will come under public health, and will be directed from there. And again, the target date for starting that would be the beginning of September.
Just back to some network of care questions here, Pat. Will CDNT and the primary care PEDS be under the children's network of care?
Again, it's probably similar to CAMS. It will be we need to. That's part of the work stream to look at, see where it best fits, and to ensure that. And again, it's re-emphasising this is setting the strategy. The people will still line management through the relevant community health area IHA manager, but it's setting the strategy, and it is. And I think the answer is yes. They both involve children. Where they involve children, absolutely. That it's to try and ensure how we have an integrated child-focused service both across the hospital and the community.
And then in relation to cancer and oncology disease, and will cancer MCAN continue to exist in its current form, or will it include to develop into the community space?
No, I think, and maybe it was missed when I said it, but all the MCANs have been stepped down, but they will re-emerge as the networks of care, which are integrated hospital and community, and to look at, and that's why I'm very eager to get the heads of service with their community background to see and focus and how we can ensure that there's many aspects of cancer care. Palliative care typically would sit under cancer in the acute sector with us. So I think there's many other aspects of the survivorship, etc., that we really need to expand in the community.
Yeah, it's one of those areas, Caroline, where I think there's huge opportunities. Both within the networks of care and the fact that they're then reaching out across the whole region and between hospital and community, and of course cancer services, as everybody on the call knows, are they're provided across all of those divides. So I think there's a real opportunity for us there with our cancer network. Yeah.
We have a question here, Tony, just more about the setting up, I suppose, of the structures. How were the IHAs decided, and was it on a population basis?
So that goes back quite a while. I'm going to say I'll hazard a guess that it went back as far as the initial stab at it went back into the regions were decided in 2019. I'd say it was probably 2023 or 2022 that the IHA boundaries were drawn up. That said, I started in my role on I think it's 1st of March 2024, and one of the first issues that I dealt with was the number of proposed IHAs for our region. At that time, it was proposed that we would have just 3 in our region, and I made a pitch to increase that to 4. The reason for that was because While population and numbers is important, geography is also important. And in our region, of course, there's very significant distances north and south and east and west, but definitely north and south. So we made that pitch, and the final decision on the numbers of IHAs emerged over the course of 2024. And so to answer the question, generally, yes, population was one of the important factors for sure. They were aiming at a reasonable standard in terms of the number of people living within an IHA. They also wanted to ensure that there was a hospital, at least one hospital in each IHA, and all of them have at least one. Some have more than one. Even in our own region, we've Galway and Roscommon have 3 hospitals between them, and there were other factors as well, but they were broadly speaking the factors.
How will service users' engagement be managed in the networks of care, and does this include evaluation processes for different clinical services?
We will have service user involvement in the networks of care, and I think getting, as Tony outlined, getting that leadership to enable us to how we get people involved, and that will be really important. And absolutely, the key to how are we assured about the service as a key component is the feedback from the service users. So absolutely, it's critical.
Pat, is it envisaged that the network of care regional governance posts will be substantively filled and via new posts, or is it envisaged that current posts will be realigned to support this, i.e. will nursing posts within networks of care for mental health, is that to be filled by a new area dawn post or existing?
Well, I suppose the existing MCAN structures will evolve into the regional network structures, and I suppose with the newer networks, we'll be sitting down there's work streams to look at what structures we put in place. Like even there isn't a rigid structure for network of care. It's going to be different depending on the care group or the clinical area of its focus. And in the acute sector, in the hospital MCANs we have, they are different. The labs is very different to women's and children's, etc. So I suppose it'll be looking at, but we will be looking to do this internally within the headcounts that we have.
And is it envisaged that GPs will be part of all of the networks of care or MCANs as they were, for example, perioperative?
Well, anywhere they're relevant, and I think it'll be really important to have their input. It's one group that we don't have enough of their input. Like you're saying, you might think that they're not that relevant to perioperative, but our main source of referral in the acute hospital sector is from GPs. So any pathways we can develop to avoid referrals or to prevent delays, they're absolutely critical, because GPs are our predominant referring base, and our referrals are the volume of referrals is increasing year on year, disproportionate to the population. So we need to look at alternative ways if we're to be able to manage services. So they're absolutely critical in every aspect of the care groups and the clinical networks of care.
Just a question here on for admin staff working for general managers and heads of service, that there will ultimately be changes for these people. So when can admin support staff expect to be notified of any such changes to their jobs?
Yeah, I think the first thing I'd say, Caroline, is that it's a very, very significant organizational change that we're trying to implement. And the changes that we've made so far are at a fairly high level. I think we're getting closer and closer now to where services are being delivered, and so it is now important as well that as we move into the IHA structures, that we consider the implications for all staff that fall within those structures as well. I think the best protocol that I would give to any member staff is talk to their line manager for whatever information they can, they'll have in relation to the changes that are happening, when they're happening, and how they'll impact them. I think our job as a regional team is to make sure that that managers generally around the system are well informed, that they have a sense of where things are going, that they have access to information, and that they're able to share that. So we've done a lot. I know that there's probably more that we could do in terms of communication with people and keeping people up to date, but we're committed to continuing with these types of webinars, with online information, with written communications, email broadcasts, and so on, to try and ensure that people are well informed. So just to go back, the simple answer really for any member of staff, regardless of what grade they're at or where they're working within the region, is if they have a question about their future role, and the best person for them to address that with is to their line manager. And then our job is to try and make sure that their line manager has as much information as she can have when that happens.
Another question for admin staff here. Could you please clarify how administrative staff who currently work across the region on tasks such as national returns and QPs will be integrated into the new structure? Specifically, how will their roles be divided or aligned across the different counties, as they would no longer have a regional brief?
I might have a go at that. So it's very difficult. I think I said somewhere earlier on that we've got 23,500 people working across the region in a variety of different roles with different, different boundaries and all sorts of different arrangements associated with those jobs. So it's very difficult to be definitive, and I'm not going to try to be. But I do think it's important that people would understand what this structure generally means. And again, I think I was very clear in pointing out that the regional structure is geographically based. We've divided that into 4 IHAs. Again, they're geographically based, and we've divided that again into CHAs, again geographically based. And I think people working within our services can expect that, in general, roles and jobs will be aligned across those types of boundaries now going forward. But we're not starting from a greenfield site. We're not starting fresh again. So we do have to take into account current arrangements, current service delivery, and how that's worked. So that will involve us engaging with individual members of staff at times to try and work out how their new roles are going to fit in specifically into that new region. But by and large, I think the focus will be to try and move towards that geographical alignment of supports and of staff.
This also goes back to setting up the structures, Tony. Is the Donegal IHA population larger than Sligo South Donegal?
Off the top of my head, I think they're not too different. I think they're close enough, but possibly slightly larger. All right, yeah. I can say for sure that that if you look across our IHAs, the largest of them in population is Galway and Roscommon, and then Mayo, Sligo, South Donegal, Leitrim, and Donegal are broadly similar. All of our IHAs have smaller population than some of the larger ones on the East Coast. But again, I don't think there's any surprises there. That's where the central population is, around Dublin. Our region is different. We're largely a rural region.
Has it been decided, Tony, if existing HR departments in the West Northwest will remain as they are, or will SAP teams, for example, be moved under the National Personnel Admin team?
Oh, I think it's fair to say, the only fair answer is to say that our existing HR departments will not remain as they are. There will be changes generally. We're not kind of going through kind of a cosmetic exercise. We're making change that we hope will make a significant difference to how patients experience our services, our service users experience our service, but also will make a difference to how staff do their jobs and how they experience their work as well. So we are trying to make significant changes that impact on that, and that does mean that there will be changes in individual departments like HR and finance and so on. Part of that change may be around roles coming out from the centre and people coming from the centre. I'm sorry, when I refer to the centre, I'm talking about what was the previous HSE centre or central HR. But that still has to be negotiated through. There's an operating model that has been completed in draft format that we're currently engaging with the relevant unions on for HR and finance and a number of other areas as well. And we're hoping to bottom that out by the beginning of September so that the changes that do need to happen can happen by then or shortly after.
In relation to network of care, are these going to be new posts or realigned posts?
I think I responded to that already, didn't I?
Yeah, all posts, everything that we're trying to do here, we're trying to do within our existing headcount. So there's from day one, from the day that we started out on this, the department were very clear that this was to be achieved. The structuring was to be achieved on the basis of existing headcount, without a growth in great drift or in significant growth in pay cost.
This is to do with, has it been decided if the HSCP disciplines, speech and language therapists, for example, are aligning to clinical managers in Galway/Roscommon? For example, our network 7, 8 and 9 staff aligning with the Roscommon clinical manager?
Would Anne want to have a crack at that one?
Yeah, I think you've said it earlier, Tony. We're working through the higher levels at the moment. We haven't gotten down to that level of detail, but we are aware that there are certain services at the moment that cross over the Galway, Mayo and Roscommon boundaries, and we'll have to work through that and work through it with the relevant managers as we progress through the structures really. But it is on our radar to actually, there are some overlaps that we'll be working through. And it may be that, we maintain certain structures for a period, or we may be making changes from the outset, but we're not at that point yet.
Okay. Tony, is there any clarity as to how CELTA Group's posts will adjust to the new regional structures?
No, is the short answer. There are some things I think that are fairly straightforward and fairly clear. So, for anybody, and maybe if I could answer this generally, I'd say anybody that has a contract of employment, our intention is that we fully honour and respect people's contracts of employment, and we also have commitments then to the unions and to other representative bodies, and we're committed to honouring those commitments in full with whatever unions that we have. So that means that we need to engage respectfully then with our own staff about changes that are coming along. I think it is fair as well then for me to say that I was CEO of the CELTA Group myself, and before I moved on into this role, and we stood down that role at the beginning of October 2024, at the same time that we also stood down the chief officers on the community side. So there's no point in me saying otherwise. That is a fact. We stood those down, and that has implications then for people that were in CELTA Group roles. What we have done in the interim period, which was that period as I described from October to March, is that we have asked people to continue in those roles and to continue to do the jobs that they were doing. They were necessary in terms of the delivery of care, and they continue to be necessary. So that's important. But we will not have a CELTA Group going forward, and so we do have to realign people in those roles to the regional construct or the IHA construct, or indeed the CHA construct. But with regard to how we do that, again, it'll be through engagement with individual staff and engagement with their unions.
I'm not sure who this service is for, but who will ID services and P&S services report to?
Ask the question in IHA services?
No, ID services and P&S services. I'm not sure. We might give clarity, Niamh, if you want to just put in what that relates to, and we'll come back to it. Another question.
It's intellectual disability.
Intellectual disability and physical and sensory.
Yeah.
So the easiest way for me to explain this is that if you look at our geographical construct again in the IHA, all services within an IHA will report up through the IHA manager. Most of our disability services, intellectual disability services, indeed physical and sensory services within the region, most of them, not all of them, are delivered by large voluntaries, either Section 38s or 39s on our behalf. So those arrangements will continue, and the management of those service level agreements will be with the IHA manager in that area, broadly speaking. That's not entirely true of the region. Of course, in the Northwest, we have direct provision of a very, very significant amount of our disability services. So that's slightly different, but still, not the responsibility for the delivery of disability services in what is currently the Northwest will be with the IHA managers in that area. The complicating or slightly complicating factor goes back to the position that we refer to on the management team, which is the regional disability lead. And there was a decision taken certainly before Christmas, so over 6 months ago at this stage, that there would be a regional disability lead in each region. And the purpose of that role is to provide coordination of disability services across the region. So it would be, and it will help provide a clear line of sight then for the department through national HSE right down into each region and down to each IHA on the delivery of disability services. We haven't appointed to that role yet, but we would hope to do so before September.
This question is there any indication on where the NCS counselling services will sit? Under mental health services now, but DOC role currently regional in terms of covering Donegal and Sligo Leitrim, and then separately Mayo and Galway Roscommon.
I'm not inclined to shoot from the hip on this one, but I think the general rule of thumb for people to work from is that the reporting lines for all services will be within the IHA. So the structures that we put around counselling services, where this question was asked, will be within the IHA in all likelihood.
And I suppose just there'll be no change until it's absolutely clear. So
Absolutely.
line managements continue. And I suppose it's a very large organization, and there's there's always going to be it'll take a lot of detailed working with it down to individual level, but I suppose there's no change until there's change.
Okay, and Pat, one for you here regarding older persons. It seems to be down the list with regard to developing networks of care, and therefore there will be no head of service for older persons for quite a while. Is there any concern that this is a risk going forward when you look at the breadth of older person services spanning home supports, residential, rehab, ICPOP, acute geriatric care? Will there be a specific IHA older persons lead in each IHA?
The answer is it won't be delayed anyway significantly. We plan to begin that later in the year. I think we don't want to do everything at one go, because just the whole trying to manage it. So, but it won't be delayed. To setting up an older people's network of care won't be delayed in any significant way. And I suppose for all the networks of care, they are going to have IHA leadership. Like we currently in the MCANs, we have hospital leadership, which reports as part of the local management team with a broken line, a link to the regional structure. So yes, there has to be, and it's how we need to sit down with each of the relevant care groups, clinical areas, and see how we work through that. They'll all be slightly different based along standard principles.
So we have a question here on where will the HSCP therapy managers sit within these proposals, given their responsibilities for clinical governance of staff performing these roles on a daily basis, and where will countrywide specialised services sit within the structures?
I suppose we've set up the HSEP. Catherine Devaney set up a group, and she looked for nominees from the HSEP leadership across the region to try and get. I suppose one of the key things we haven't had, and it's made it challenging, there isn't structures at a regional level for HSEPs. And how we put that high-level structure in place, a communication so that we can get representation, involved in the various groups that we're working to develop the structures, and also how we communicate up and down to the leadership at the HSCP level. So absolutely, their HSCPs are a key part of the multidisciplinary team, and they are and will be involved.
Pat, are networks of care being developed in the same way across all the regions?
No, the broad construct of networks of care was part of the initial rollout of the regional structures. I suppose we had more evolved regional structures. So did the Midwest. But I know from the Midwest and the Southwest are definitely following a very similar approach to us. And the different regions will evolve in different stages. I think there's different issues there. We already had a fairly clear regional structure with geography, etc. The other regions in the East Coast are still realigning from previous structures, but I expect that the networks of care will evolve from them in due course.
And
Yeah, Sorry,
Tom.
Karen. No, there was a decision taken that there's a national steering group that's overseeing all of the implementation of these changes across the country. There was a decision taken a number of months ago to progress with pilots in older people's services and children's services in a couple of areas around the country, but also the decision was taken at the same time to continue with current arrangements where they exist and to develop the current arrangements. So that's actually what we're doing. We're taking an arrangement that currently exists within our region and making it work for the region. Yeah.
Another question here on networks of care. How will they attempt to balance the current lack of equity to access to specialists across different counties in the network?
Well, I think that's part of the challenge that I'd be asking them to come to look. And I think one good example that we've had from the hospital sector is where the medical MCAN have done a comprehensive review of the needs of neurology services in our hospitals, and set out what is required at all our hospitals in the region to have an integrated delivery of neurology services, so they can be delivered as close as possible, but where the specialist services are at the regional level. And that's the sort of model that I want replicated in multiple other specialties, care group areas, is setting the standard and ensuring that we have you can't do everything everywhere, but that we have an integrated approach and that the care is delivered as equitably and as close to the patient, the service users' home as possible.
Tony, at last year's staff engagement, clerical staff on temporary contracts were mentioned. Is there any update on clerical staff that are currently on 3-month contracts and any plans to extend this time frame?
So the short answer is probably no. There is no significant update. Last time around, I would hope that what I said was something along the following lines, that it's not desirable for us to have people on 3-month contracts. It's not good for the person themselves, not knowing where they're going to be in 12 weeks' time, or whether they're going to be still with us or otherwise. That's not good for the individual, for sure. It's not what people want, but it's also not good for services. It's not even good from a practical administrative point of view that you have to continue to renew contracts every 3 months. It doesn't make a lot of sense. So in general, it's not a good practice. I certainly understand where it came out of, and I understand the history here. So, but I would like to see that we're moving away from it, and I'll work with our HR department to try and do that. I know it's not straightforward because there are panels and there are lots of different hurdles that have to be kind of minded as we work our way through it. But fundamentally, the idea of having people on short-term contracts that we roll over, that's not a good practice. It's okay to have a short-term contract if you only require the person for the short term, but outside of that, we need to stabilise this.
This one now is, what is the planned date for the Sligo Leitrim to take responsibility for South Donegal, Ballyshannon and Bundoran?
I don't know if John Fitz is on the call. It might be one for John to jump in on, or Dermot maybe.
Sorry, Tony. Yeah, I missed the first part of it there. Go ahead.
So, John, the question was, what is the planned date for Sligo Leitrim to take responsibility for South Donegal, Ballyshannon and Bundoran?
Well, really, a lot of the work has been done in regards to that, so it will coincide with I suppose, the September timeline. The only bit that's outstanding, I would say, is in regards to mental health, and we're working through that. So pretty much in line with the establishment of the IHA structures in terms of the governance arrangements, the new governance arrangements in September.
Tony, this is another sort of HR question. You mentioned the restructuring of certain departments may happen. I know it's hard to say at this stage, but do you envisage that the restructuring under the IHAs will bring about a possible redistribution of administration staff to under-resourced areas?
That's a tricky question in a way, because at a level, if we've got an under-resourced area, and I suppose the implication is that there are other areas that maybe have more resources that could afford to release some staff, we should be doing that anyway. We don't need a restructuring in order to make those types of changes. That said, I'm not naive, and I've worked in the public service for a long time, so I know how difficult that is. First of all, to identify where there might be an over-resourcing. I think the under-resourcing piece is easier to identify for sure, but it's very difficult to identify areas that are over-resourced and then to engage. What I would say is that that the process should be about trying to ensure that we have enough of people meeting the highest priorities for the region. So first of all, we have to be clear about what our highest priorities are. And then we need to engage with staff in a respectful way, and in a way that makes sense as well. There's no point in looking to transfer staff or from Galway up to Donegal or vice versa. That wouldn't make any sense. But within locations, it should be possible for us to do it and to manage more effectively in that regard. That's a very vague answer, but I don't think we require the restructuring in order to be able to do those kind of things, and I don't think that the restructuring will necessarily help us.
Is it envisaged that all health and well-being staff and functions will transfer to public health?
It is, and I'm hoping that Anya McNamara is on the line. It absolutely is envisaged that health and well-being would move in that direction. And actually, I think since our last webinar, that's one of the areas that we've done a lot of work on, and one that we've arrived at some conclusions on, that it is a good fit for health and well-being to come in under public health. And again, it's one of the areas that we're working hard on so that we can deliver on that by the beginning of September. Have we Anya on the line by any chance?
Yeah, I'm here, Tony. Yeah, we've. I think the broad consensus is that health and wellbeing will move under public health. There are one or two small discrete services that we'll be discussing over the next week or two about where the best fit for the population. Would it be in the IHAs or with public health, and hopefully have clarity for people in the next couple of weeks. But in general, the principle is everyone's coming into public health, and we're working on that over the next few months to get it done by the deadline, as they say.
Do we have any update on the community finance structures to date, or when it will be communicated?
So I'm not sure if Liam Fogarty, who's our Regional Director of Finance, is on the call. If you are, Liam, feel free to jump into this one. It goes back a little bit though to what I was saying about the operating model for finance. So what we're trying to do is to have a model that describes how finance will run from national HSE down through the region, and then within the IHAs and down to the CHAs, so that it covers the full remit. I think the short answer to the question was asked is that we don't have that agreed yet. We are working on it with the unions. We have a draft operating model which isn't fully agreed yet.
So, Tony, this is just a comment. There has been an increase in undergraduate nursing students over the last few years following the National Staff Nurse Planning for the Future, but the number of staff directly related to their training within clinical sites have not been increased to match the numbers.
So what hasn't been increased, sorry, to match the numbers? The
number of staff directly related to the training.
Okay, I suppose first of all, I agree there has been a significant increase in the numbers of student nurses, and indeed in general there's been an increase in the number of students across a range of disciplines, and that's necessary. We do need we've grown the number of people working within our service quite significantly over the last 5-6 years, and our plan is that will continue to be the case. And of course there are significant gaps in some areas, so we do need to be training more people for sure within our region, hopefully to continue to work within our region as well.
So a few more questions here, Tony. Should the population be able to access screening locally, for example, colon and breast screening, cancer surgery and LUH?
So the screening program will continue to be run as a national program, and I would be very supportive of that approach. Screening programs on a number of fronts. So we've got cancer screening programs, but we also have screening programs for diabetes as well. So they will continue to be managed and run at a national level. I strongly support that approach, that whole population approach. They're the kind of numbers that you need. That said, they do integrate well, and they always have integrated well with our local services, and I would expect that to continue. One of the key issues for me will be particularly around services like cancer screening, is the important role that they play in terms of cancer outcomes within our region. And some of the, one of the issues for our region is that our outcomes for cancers generally are not as good as the other regions around the country. So I would like, over the course of the next 4 to 5 years, certainly in my tenure as regional executive officer, that we make inroads into that. So a big part of that has to be around screening and having that connection between those national screening services and our cancer services.
This one just relates to the time frame for implementation, Tony. If we are still only working out the high level changes and with staff on summer leave, 10 weeks to the 1st of September, is this still a realistic time frame?
It definitely is, and I know that people kind of get a bit of a reaction when I say things like that, and some of that, sometimes I know the reason I'm saying is because we have to have deadlines. Deadlines encourage or help us to make decisions, and this is complex stuff with very, very few black and white decisions. Nearly every decision that we have to make around this is, about balancing risk or balancing benefits or balancing costs and so on and so forth, but it's all about a balancing piece. So bringing us to the point of decision is very important, and deadlines help with that. So our deadline of the 1st of October last year, when we had it, helped us to get to the point where we had our IHA managers in post and our IHAs established. And I think the 1st of September deadline is a really good one, because it'll help us to focus the decisions that need to be made in order to make sure that we have the structure in place underneath those IHA managers, so that we make that connection. So yeah, we won't have everything done. There's no question we won't have everything done, but the question is, will we have enough done in order to be able to safely transition at that time over to the new structure? And I believe we definitely will. I think we're very, very close to it now. We have a lot of work done within our region, engaging with people about how things should look, how they could look, and how they could work. And I certainly am getting a strong sense from lots of people that they want to get on with it now, and they want the clarity that will come with having an established structure.
This is a HR piece. Will local staff be prioritised if there are people being reassigned from the HSE centre?
I'm not sure that I fully understand the question, but I do think it's fair to say that that we've had a lot of engagement through our HR department, both regionally and at national level, with the unions, and we've agreed parameters within which we will engage with staff around key issues like reassignment in terms of their role or even in terms of their location. I would like to reassure staff that our intention is to work carefully with staff in terms of getting the best outcomes, not just for the services, but for themselves as well in terms of their own career, their own working conditions. And we'll continue to engage and work with the staff representatives of the unions to try and achieve that as well. We're not interested in kind of trying to shoehorn people into roles or positions or locations that don't meet with their needs or meet with service needs. We are interested in making changes that make a real difference for the patients that we're serving.
Tony, do we have a timeline for disability home support services to be integrated within the new structures?
I think it's not all black and white, if you know what I mean. I think what we will have is that we'll have significant integration by the beginning of September, but with still some work to do, without a doubt. Yeah.
Will each region be developing their own regional PPPGs and clinical guidelines for implementation, or how will this align with the implementation of national PPPGs and clinical guidelines across the organisation that are currently in place? They're saying it's not exactly clear what the function of HEPA is going to be.
Might ask Pat maybe to jump in on that.
Yeah, no, we won't be developing. I mean, we'll be working to implement, to develop strategies to ensure that we implement national policies, procedures, guidelines. We won't be creating our own that are at variance with national, but in many instances we need to put the focus will be how the network of care takes a national guideline and implements it in a consistent way, and looks at it that we ensure equity across the region, and that we're ensuring standards that we can monitor and be assured about the services. So no, we won't be doing other ones. We will be taking them and making where there isn't ones that we need, developing them locally, but where national guidelines are, we want to ensure we comply with them.
So the next one's more of a comment than a question, but it's just asking for greater levels of HR planning, that the staff post-approval panel setup process is expedited, and that it would be super across the region if we could get to a place where staff retiring, going on maternity leave or resigning, had a day of handover with the person taking over from them. It would make a huge difference to service provision, meeting KPIs, waiting lists and customer satisfaction, along with staff satisfaction. Experience tells us that if we keep doing the same thing, then we will get the same results. It's just to bear that in mind from HR.
Yeah, and we're happy to bear it in mind. I also, I suppose, I think there's things that we would definitely do in an ideal world, and in an ideal world we would have those types of handovers in every circumstance when somebody is leaving, whether it's for a short-term leave or maybe leaving permanently or retiring. I think the truth is though that we're finding it difficult to do that, and the reason that we're finding it difficult is because we have significant demands on our service, significant unmet need, being honest with you, within our services, and we have a relatively limited resource now. So continuously deploying people to meet those demands is the challenge, and sometimes what gets squeezed is things like those handovers. Not that they're not important; they are important, and they do impact on the care that we provide. But it is difficult for us to achieve it. One last point on employment that I would say is that while it kind of created a lot of angst, and I understand where that comes from, the pay number strategy has given us a level of certainty that for at least for coming up in 12 months, in July it will be 12 months, for nearly 12 months now, we've had that certainty, so that we know that if somebody's going to retire in September, that a good chance that the application for the approval to replace that person will appear through the line in front of me in advance of that, and the clearance is given and the approval is given. And we've done that. We've been replacing posts on a consistent basis since the 1st of January 2024 on that basis, and done reasonably well in terms of maintaining staffing levels across the region.
Tony, is there any update on where the CMSUs might report to within this region?
Yeah, so not fully decided is the short answer, but we have two CMSUs reflecting the fact that we had two CHOs, broadly speaking, within our geography. So ideally what I would like to see is that the two CMUs operate as one, and I think the most likely home for them will be within finance, actually. albeit that the work that CMSUs do is really, really important to the SLAs that I referred to earlier on, for example, with our big disability organisations. So maybe with a straight reporting line into finance, but obviously supporting the work of the IHA manager, because the IHA managers are going to be managing the delivery of those services. So it's not, I mean, you know, I think it's very doable. It's a little bit, it means that they have to be keeping an eye on both on finance and the IHA managers. Yeah.
Okay. We have a question here again about HR. Will grade 5 community panels be extended, and will there be jobs coming up?
There will, well, it's easy for me to say that there will be jobs coming up. There will be jobs coming up because we know that, you know, in any given month that vacancies arise because people retire or resign, get promoted, whatever, you know, so there will be vacancies coming up for sure. And because they're coming up within our head count and we're operating within that, we'll have the freedom to be able to approve those and to move those forward. Will the panels be extended? The short answer to that is I don't know, and I wouldn't hazard a guess in it, because I know that there are implications for people that are on the panel, and there are implications for people who would like to be on the panel. So that's one that I would recommend that you take up with your own local HR department, and we take it then from there.
This is just down to, I suppose, the communication structures. Will the new structures endeavour to engage staff at the coalface with regards to individual services? Example, the media knew more about the PN service and the SUH than the staff in the service, fears that it makes them look incompetent when answering patient queries. Delighted that a new consultant has taken up the post, but was heard on the grapevine. So that's just something to bear in mind for us all.
Yeah. I mean, yeah, I completely get it. You know, it's a big region, a huge population of staff, and the challenge of communication across our region is very, very significant. So it is, we're always open to suggestions that people might have you know, how we can do better, and we'll definitely keep trying to do better. But I know it's a huge challenge.
This is a question for ophthalmology. Has it been decided what IHA community ophthalmology in Sligo, Leitrim and Donegal will sit under?
Tony, I'm happy to come in on this. We actually have a meeting about that this afternoon, so under discussion.
Okay.
How do the regional finance, HR and IT functions interact with their national colleagues? Where does the overall responsibility for these functions lie? Is it regional or national level?
So I don't think, well, I know we don't have Liam, and I don't think and I know we don't have Maria, but Vincent, you might want to jump in on this one from an IT perspective, and it might help to paint the picture as well for other functions. Yeah.
Yeah, and I think that historically all of the decision making has been centralised, and we've had a very mixed environment. There's been local differences and local variation. Okay. And I think that what we've seen over probably a long period is a continued centralisation of the resourcing available, at least on the ICT and the digital side. I think with the new arrangements and the plans for Sláintecare, we've been arguing very strongly that we need to devolve some of the responsibilities, certainly in terms of ensuring that we're dealing with the issues that allow us to deal with the patient safety and the risk issues that are manifest in our area. So some of this is about how the decision rights change, and some of it is about how do we put teams together to make sure we're delivering for patients and delivering to the staff that are working with patients. There's been a piece of work commissioned by the Chief Technology and Transformation Officer and the Deputy CEO, Damien McCallion, that is coming towards a close, which is about trying to set a new operating model in the digital space. I think there's still some further work to do to get to a place where we will be able to better serve the patients and the staff in this region. But there's a draft coming together on that, which I'm hoping to get my hands on fairly soon. But I think that we are working as closely as we can to try and get the clarity that we need and make sure that we've got the resourcing that we need to deliver effectively within region on as much of the digital agenda as we can. Okay, but I do recognise that this is a challenge for us across the country, and it's something that I think we've only recognised in the last couple of years, that we need to invest more in our digital capabilities, and in particular in our staffing and how we do that well. That's very welcome additional investment from government. We know government are under a lot of pressure with their investment choices, but the increase is very helpful. But how we actually make sure that's landing on the ground in a way that improves the digital experience for our staff and for our patients, we're still working through the details of that, but it's definitely something we're very engaged on.
Yeah, it's important. I think I'm just reflecting on the question. How do they interact with the regional? How do regional HR, finance, and IT interact with national colleagues? So it's important, I suppose, that we remember we are part of a national system, and in many respects, it's that becomes really, really important. I think Vincent's area is one of those for sure. But so is HR. It's very difficult to do an agreement that only impacts on one region that doesn't have implications, for example, on staff working in other regions as well. So we do need to have that kind of connectivity. One of the ways that in the last 6 months that we've seen that develop is that the National Director of HR, Anne-Marie Hoy, meets on a regular basis with the 6 regional directors of people from the regions and, coordinates some of the discussions, some of the engagement and so on. And what we've seen over the last while is that our regional people, including myself actually, are getting more and more pulled into national discussions, national engagements, national negotiations, national planning, and that's good. It means that that fluidity, moving back and forth between the region and the national informing the region informing the national. That's happening in an increasing way over the last 6 months. So it's different, a little different for finance and IT, but yeah, I think there's potential there for us to work on that.
In one of the slides, we mentioned that the GM for a CHA will have operational responsibility for the majority of community services in the CHA. Do we have information as to which services are included or not included under the remit of a GM for a CHA?
I think actually the slide, and one of the other questions was, will we share the slides? We definitely will, but I think there's detail in the slides that might help people to understand that, yeah. And
just to note, all the slides will be circulated, and this recording of this webinar will also be recorded or circulated to everyone, so they can listen back. You mentioned about a commitment to training staff within the region. Does this commitment extend to development continuation of postgraduate programs? And within the speciality, would they fall within the relevant network of care remit?
I'm going to ask Anne to come in on this one because I know that Anne has some experience on this. So we've had some really good examples over the last few years that we're going to build on over the next few years of where we have provided training for key disciplines so people that are already trained in a particular way or working in a particular way, and that we're providing them with training so that they can reskill and move into different areas. I'm thinking of radiography and the medical laboratory aids, and there are other examples.
We've had 2 examples, I suppose, most recently in the last 3 or 4 years, specifically with UCC in Cork in relation to postgraduate training of applicants to become radiographers who would have a primary degree on the basis that they're actually placed within our region, the West Northwest, and we committed to that for two intake programs, and for a number of years we've been sponsoring. Some of it was being sponsored nationally, but we had started ourselves locally to sponsor staff to train as medlab aides, or who are medlab aides, to train to become medlab scientists within our system, and that similarly has helped us to actually provide I suppose a supply stream for some level of posts, because there are scarce grades and we do have to look at that. We also, I suppose, would link with and have been linking with the ATU in relation to new programs being established, that may provide, cardiac physiologist, vascular, respiratory physiologists, etc. within the region. And as Dermot mentioned earlier, working with, colleges and the ATU potentially in relation to HSEP, particularly physiotherapy. So we're always looking at these opportunities really to, where we can, and particularly where, it's difficult to recruit into. And we're also, I suppose, encouraging the universities where we know there's a need to try and train graduates within our own region. So, for example, the new pharmacy school opening in the University of Galway as well. And our ultimate aim would be to have a school of radiography in the west or northwest region also, so that for some of our key kind of staff that we would have those, coming to us. And obviously we have our nursing schools with the ATU and the University of Galway as well. So there's lots of different synergies, both at undergraduate and postgraduate level that we're continually promoting within our region.
Thanks, Anne. But just back to the networks of care, but we speak about integration being central to this and IT systems that communicate with each other. Are there plans to employ the IT people we need to do this, as it's essential for the whole process?
You jump in there, Vincent? Yeah.
Yeah, I can jump in there. So I think just to maybe to build on the answer a little bit earlier, there's been for the first time in a good few years an allocation of posts from the National Service Plan 2025 to the region in some digital roles. It still feels very modest. Okay, there's I think we've been notified of about 6 roles in total for 2025, and we're in the process of recruiting those, as well as a small number of additional temporary roles. So I think, Michelle, we're continuing to argue for an increase in that, but I think it's clear that for us to get to the scale that we need to do that within the headcount that we have in region as well. And that's really, really tricky. And we had some of a conversation around this yesterday in the integrated care steering for digital. And every service is under pressure for their staffing. And it's especially difficult to find people saying, well, I can do without that vacancy so that we build the additional digital capability and capacity to move forward. So that is a really hard issue, and I'm fully cognizant of that. But we won't get to the scale we need just from development posts through the service plan. We will continue to argue for that, but we will need to find ways of people working through digitally enabled transformation from within their existing roles, and we will also need to allocate additional parts of our headcount into the digital roles to get to where we need to be to deliver that integrated care. But I think it is well recognised across the regional management team how important and how enabling well joined up solutions are, and we're certainly striving to put the right staff in place to deliver that.
The next one is really, I suppose, for comms in a way, because it's is there work and guidelines issue around the branding and signage, including email sign-offs and the cost of same. For example, the Sailta logo is still widely used. So I'm very disheartened to hear that, because we've issued out a good few times asking people to go with the new branding, which has been shared. And David, we'll share that around again. I appreciate with signage, it's a different situation. And I don't think anyone's in the business of pulling down perfectly good signs just to change a logo at this stage, but that they are things that will be iterated out with time, and the same was with bigger letterheads and such, once there wasn't any great cost involved in changing of them. I don't know if you want to add to that, Tony.
Well, except I'm smiling a little bit at the question, because not alone is the Sailta logo still used. I still see the Western Health Board logo used and the Northwestern Health Board logo used. So yeah, I think you're exactly right. We're not interested in pulling down perfectly good signs to put up just for the sake of a new logo, but there are some things that can be changed at relatively low cost with a bit of coordination, like email sign-offs and so on, that help to create that level of integration which we're trying to achieve, and help the sense of identity that people want to be part of as well. So I think we can do that, and we will do those things as well. Yeah.
Just back to recruitment. Will recruitment attempts be prioritised to support the Letterkenny Breast Centre with a second breast consultant and radiology breast consultant?
So I think this might be one for Pat and for Dermot, and I'll certainly support my support for it is straightforward, but Pat and then Dermot.
Well, yes, and I'll let Dermot come in, but we're fully supported to maintaining the breast unit in Letterkenny, and to ensuring that it's staffed with a second surgeon, and ensuring the radiology staffing is adequate there. Absolutely.
Yep, that's true. That's been processed as we speak.
Yeah. So and just to add to it, and it's again, that support for the centre in Letterkenny extends all out to myself and beyond.
Okay, folks, thanks very much, and thank you all for bearing with us on this. I think we've covered all the questions that we have across the chat and Q&A, but Tony, if you want to...
Do you mind, Caroline, if I just round up a couple of quick points of emphasis, and they really are just quick points of emphasis. So the first point of emphasis that I'd like people to bear in mind is early September. That's the important date. If you've missed it over the course of the last hour and a half, that's the important date. We are working hard towards that as our deadline. We won't have everything done, but our aim is to have enough done to be able to move ahead and then to continue to work after that. Early September is an important date for me. I think Pat made a really important point as well. It's a safety point, which is that that we're not making change without clarity. So, if you're wondering, is my job, my role, my location, whatever it is it going to change? To talk to your line manager about that. But until we're absolutely clear on what the arrangement is for you to move on to, we won't be implementing change. We won't be heading off into any vacuums. And I think that's a really important point as well. I would say that that for sure that I am anxious that we progress at this point. It's always important that you get a balance right between giving enough of time to be able to engage and to work with people, to listen to people, understand what the concerns are, and to take those on board and designing new structures. But getting the balance between that and taking so long at it that you leave a level of instability within the structures. That's kind of where we're heading towards right now. So it is important that we move ahead at this stage. And if you get a sense of kind of impatience from me, that's where it comes from. It's about trying to make sure that we keep things as safe as we possibly can. I want to finish, Caroline, on this point, and it's to acknowledge the work that people have put in getting us to where we are in terms of our structures right now, just as I did at the start. I definitely get a sense from people that they don't just want to make change for the sake of it. I definitely get a sense from people that they want to put a structure in place that supports the delivery of really good care and is, makes it a good place for us to continue to work in. So the responsibility on myself and my colleagues in the regional management teams to try and deliver on that for you. So we'll work hard at that.
It's great. Thank you all, and thanks to everyone for attending today. As I said, we have recorded this and we'll share it out to all staff along with the slides, and we'll have another one in the diary in September, hopefully, Tony. So we'll catch up then.
Thanks, Karen. Thanks, everybody.
Thanks.